This is the BioCentury Show.
Brought to you by the 5th East-West Biopharma Summit in South Korea. In March, explore how to globalize Asia innovation and connect with key players across Asia's innovation arc, from India to China to Japan.
Welcome to the BioCentury Show. I'm Executive Editor Selena Koch, and I'm delighted to be joined today by Bill Hinshaw, CEO of precision oncology company Fore Biotherapeutics. This is Bill's second time in the role of CEO after 5.5 years of leading a biotech called Excella. Before that, he spent 14 years-ish at Novartis in a variety of commercial and business leadership roles in oncology. So what occurred to me, Bill, was that from your time at Novartis through to today, you've really seen the story of precision oncology unfold. From Gleevec, I think, which is often credited as sort of the birth of precision medicine, to Novartis's asset swap with GSK, where it got BRAF and MAP kinase pathway and other assets, to Fore, where you're now trying to take that BRAF targeting therapy up to the next level. So I kind of wanted to start with some of the history to pick your brain on that range of experiences and kind of paint a picture of how precision medicine has evolved. So let's start with Gleevec. It was approved in 2001, and I think you joined Novartis a couple years later. So it was approved, but not yet scaled, right? And so when you think back to the challenges that you faced then and what you were trying to accomplish, which of those would you say are still relevant today, and where has the field moved?
Okay, great. So first, Selena, thank you very much yourself and BioCentury for having me join you today. I'm honored by that and really appreciate the opportunity. And you're taking me back to some amazing journeys and experiences on that piece. And as my beard will display, I'm old enough to know before precision oncology was part of cancer. In fact, I grew up at St. Jude's Cancer Research Institute with my mother. So Gleevec was indeed a remarkable innovation forward. And so if we start with the concept that you're looking for macro picture wise for precision oncology, of course, it's to be able to identify a specific driver of cancer and then have a therapy to address it in the appropriate way. And that should allow you to achieve better outcomes, right? That's the goal, right? And ideally, you'll also do that in a very well-tolerated product because you're eliminating a lot of the off-target effects that lead to side effects and consequences. And so if we think about Gleevec, Gleevec was designed to address the BCR-ABL translocation. It was a very good drug to do that. We improved on it at Novartis, which I'll get to in a minute in terms of the opportunity. But in terms of precision medicine, first you have to have a biomarker. You have to have a biomarker that requires tissue, right? And in the early days, what we faced was the sequential technology and reimbursement model. So what do I mean by that, right? Anytime a new therapy or a new innovation comes out, you have to scale it to your point. You have to make it cost effective, and then you have to figure out how it fits into the treatment and workflow. And the issues we faced early on were the fact that you first had to have the tissue, then they were doing a one test, BCR-ABL in this particular case, right? But it could be something else. Could be Philadelphia positive ALL, could be something of that nature, right? And then that test doesn't evaluate that for that patient. Do you get more tissue? How do you get tissue? How long does it take? If you don't have a therapy, is it reimbursed? How do you get the chicken and the egg, right? So this was part of the early parts of this. So tissue, limited labs, testing technology and sequence, time to get the outcome, and then reimbursement. And this all affected outcomes, because if you're a clinician or a patient and you're waiting for that, and it takes weeks and weeks, I'm going to put you on another therapy, right? So this was the early days. Now, we were very excited about the ability to identify patients, and instead of a 7%, 10% response, get an 85, 90% response rate. Amazing, right? And that's what we were able to do with Gleevec, was change the natural history of the disease. But what it required, to your point, was scale, reimbursement, technology and cost improvements, so it could be broadly available early in the diagnostic journey and not, like I said, in sequence. Think about trying to get a brain tumor tissue or a lung cancer tissue or a liver cancer tissue. Those biopsies, those activations, and this is before we can move to blood, plasma, circulating DNA, So that's what it was. And so we weren't able to fulfill the promise as fast as we wanted to until that scaling happened.
What would you say the state of that diagnostic journey is like today? And what are the issues still remaining?
Yeah, so it's radically different, and it's been awesome to be part of that, leading both the European and U.S. Parts of U.S. oncology for Novartis and many others that contributed to that role across the industry. But so what's happened is indeed we've scaled technology. So now it's a broad panel. Instead of a sequential individual alteration or mutation, you can take the tissue or the plasma and test across a broad panel of mutations and alterations. That's critical. Okay, that piece. The other aspect is it's available both in central and local laboratories broadly. So depending on where the patient is initially diagnosed, they have that available. And because of the scale and cost, now it's much more broadly accessible and reimbursed. And we've seen that with an explosion of precision oncology agents. And by the way, we're at a remarkable time in innovation in cancer. You have true new innovations in radioligand, in cellular therapy, which I had a chance to be part of, gene therapy. Targeted precision oncology is still the largest number of approvals by the agencies regulatorily and in the business world. And that's because it plays a fundamentally important part. So that has changed radically. It's also incorporated into NCCN guidelines in terms of the nature and timing of the testing, which is important because that drives pathways and reimbursement. And so from that standpoint, now it's a much different place than it was even a decade ago. Now, with that said, the second part is what's still there, right? So while it is widely used in a number of cancers, think about melanoma, colorectal, lung, these are all tested more than 90% in the United States, okay? But there's still some patients who don't get it early. And then you also have the dynamics of timing. How fast can we turn this around so the clinician and the patient can take their treatment decision? And then the other piece is what's the relationship between different mutations, right? And what would that translate in terms of a sequence or a combination of treatment can be very important for patients because where there are limited options for the patients, the clinicians obviously want to provide the maximal benefit over time. And that can be in relation to the original mutation, resistance, or mutations that happen to that, and what either individual or combination of drugs that are used. So there's still need, and it still needs to be used more and more integrated, but we're far advanced from where we were 5-10 years ago, which is awesome for the patients of the medical community.
Yeah. Are patients now getting retested upon recurrence?
That varies, and that varies by disease and which options are available.
Yeah.
Because to retest them, again, sometimes depends on the location of the tumor or the metastases. Obviously, certain are easier to access than others. And the trauma that goes with that, right? Number two is, okay, what do you do with the information? And are there alternative therapies available or not? Now, sometimes that can set up for clinical studies, of course. And so that activity, it ranges much more widely than the upfront diagnosis. It does occur fairly routinely in disease areas where there's either resection and or clear lines of therapy, and certainly in major institutions. This is important. Think about advanced breast cancer and other areas where there are lines of therapy dictated by the progression of the disease. I'm excited by the continued advance in circulating DNA, bloodborne tests, things that are easier to access, but we're still dialing in some cases, the utility, the availability, and I'll say the precision of those tools.
So as there's greater testing penetration in the various formats that there are these days, it seems like there are new, very rare tumor drivers being identified all the time, and you get this increasingly fragmented cancer indications. From a patient perspective, you'd really want therapies for every single one of those. From a business perspective, you have some constraints, right? So when you think about how do you weight the variables and what makes a viable business proposition today, how do you weight factors like the indication size versus the ease of diagnosis versus how deeply understood the biology is, or the ability to maybe use it against multiple subtypes? How do you think through that?
Yeah, it's obviously a complex dynamic as you outlined through the structure of your question. I think fundamentally science and knowledge has to drive it. In other words, do you understand the biology as you alluded to? How does that translate into an ability to identify, select for the patients, and then treat them appropriately? Now, so there are clear paths that you can go down. BRAF, MEK, ALK, ROS, EGFR, et cetera, right? That allow you to know you have an innovation, excuse me, a treatment, and then you can identify and have a discrete population, test a therapy against that population based on the science of that therapy. Do you have the right mechanism? Can you get the product where it needs to be? Can it have the desired effect? And can it ultimately be tolerated and achieve the outcomes for the patient? That all has to come together, Selena, right? And then you can look and say, okay, smaller patient population still, thanks to both I'll say the focus of the industry, the commitment of patient groups, and the construct that the government agencies and others have put in time, can be realized. But you have to understand, can we help the patients? Can we identify them? Is the science adequate? Otherwise, you're working alongside of your additional data to advance that over time, but you may not be able to take the big step right away. You have to have some of those foundations in order to make that a good business decision while the science is continuing to advance, and now you can act in an informed way.
You talked a little bit about a chicken and egg problem. Like, there's no reason to test for a certain mutation if there's not a therapy against it, but it becomes much easier to discover therapies if testing happens. With this increasing fragmentation, is the testing still being done on just the most common known drivers, or is there more than that being done that can help drive the science forward?
So the answer is more is being done now. That's one of the big advances of both the broader panels that are done up front, as well as, of course, leading academic institutions and medical institutions and the scientific work that is gathering more data as we progress. And that was a huge, important impact technologically to allow us to leapfrog just a very slow sequential sort of approach. Now, is it fully optimized? No, it's not fully optimized yet, but that is what's allowing us to identify potential mutations or alterations like infusion in my world. Okay, this is an alteration that has very limited treatment options available currently, but now it's available centrally as well as in local labs because of both that combination, which was the core of your question of where do you progress in a business decision, is, okay, we have data that we're gathering that's allowing us to inform ourselves, test and develop our product against it, and hopefully move forward. So it's in a much better state than it was, but we can still make progress on this because macro picture wise to your listeners, cancer by itself, without all the mutational breakouts or alteration breakouts, it's more than 200 diseases already. So now we're trying to segment. It has to matter, meaning that driver has to be a key driver of the disease or the resistance, and then we can hopefully identify the right approach to intervene.
Well, I want to ask one more question before we go to our break. So all this progress that you've just described, when I think about like the early examples of precision medicines that come to my mind for oncology, they were all brought to the market by the large companies, right? Has this progress, you think, systematically or meaningfully lowered the barriers to entry for smaller companies as well?
Yes, the landscape is established. Okay, what's the pathway for regulatory clarity on the diagnostic and the companion diagnostic needs? Okay, what is the path to identifying and enriching the patient population? What are the outcomes that should be measured appropriately on that particular patient population? So that path is much more clear than it used to be, okay, in terms of this space. Now, it still requires excellent science, rigorous understanding of the patient population and what other factors could drive their outcomes. And how do you then focus and deliver that? I'm going to step back a little bit, Selena, from the standpoint that this is an ecosystem. So one of the reasons why I stress that targeted therapies and precision oncology is still a really important part of the regulatory and commercial marketplace is we're going to need those as a foundation as we also innovate in some of these other mechanisms and approaches. And so that combination needs to work together to build better outcomes for our patients and society.
Right. But small companies will often still say, oh, it's really hard for us, particularly if a companion diagnostic is needed. We don't have the skills to do that, this and that. But I do think more providers are maybe available now that can help companies outsource that piece of it. What's the status of that?
Both things are true. Okay, if you will, right? So it adds additional responsibility in order to get the product approved and to market, is you may indeed require a companion diagnostic strategy and data set. You always require a data set, but if you have to develop an entirely new companion diagnostic, that requires additional capabilities and or resources. Now, to your point, the ecosystem across diagnostics has continued to expand and evolve, and in a number of cases offers real-time testing and other capabilities, but you will have to budget for that, you'll have to plan for that, you'll have to coordinate, and in some cases you're starting from scratch if you're innovating an entirely new alteration or mechanism goal, and that does require more and has more technical risk than other paths do. So from that standpoint, there's a path, but that doesn't mean it's easy. And it does require commitment and resources in order to do that.
Yeah. All right. So we really have to take a short break now. But when we come back, we're going to turn to Fore Biotherapeutics and the opportunity for differentiation you saw there. I'm also keen to hear about how you're picking and sequencing indications. So we'll be back shortly.
The BioCentury Show is brought to you by the 5th East-West Biopharma Summit in South Korea. An arc of innovation is emerging across Asia, and Western biopharma leaders are taking note, from cross-border deals to new co's. In March 2026, the 5th BioCentury Bay Helix East-West Biopharma Summit visits South Korea for the first time. Meet the biopharma leaders putting Korea innovation on the global map. Learn why Korea has become a clinical trial and manufacturing hub. Discover if Korea is the next hotspot for new co-formation. Plus meet biopharma innovators from India to Singapore to China and Japan. Register now at biocenturyeastwest.com.
Welcome back to the BioCentury Show, where I'm speaking with Bill Hinshaw, CEO of Biotherapeutics. Now, let's dive into what Fore is working on, because, Bill, your background with Tau and lower mechanists, at Novartis, I think make you pretty uniquely positioned to recognize differentiation in the BRAF MAP kinase space when you see it. So what convinced you that Fore's program had sort of the right mix of attributes to really meet that bar in a space where there were already agents?
Yeah, Selena, it was in line with what you're articulating. For me, it was the differentiated first-in-class mechanism of action, which is called the dimer breaker, leading to paradox breaking. It was the magnitude and consistency in results in the clinical data that we had already demonstrated in large phase 1/2A across multiple tumor types, showing really profound response rates, and even more importantly, the durability of the response rate due to the tolerability and safety of the product. And lastly, it was indeed the indication space and the potential, as we like to say in the industry, to disrupt an underserved and large important alteration cancer with a leading profile. And so that was extremely compelling to me and why I joined Fore at the time I did.
So what are the structural innovations in the molecule that lead to specific types of differentiation?
Okay, great. So let me start with kind of the background and then the context and why it's differentiated. Okay, so in BRAF is part of the MAPK pathway, which is one of the most dominant pathways in all of cancer. And so in the case of the first and second generation agents, They bind to the BRAF in the dimerization process, but they hyperactivate downstream, which leads to ERK activation and ultimately skin growth and skin cancer risk. So the early innovation that Glaxo colleagues had that we then were able to pull in at Novartis when I led that team was the combination of a MEK inhibitor, not for the traditional efficacy, but for safety in this case, right? And that was able to mitigate some of the risk, but came with its own, including ocular and cardiovascular risk. So the scientists at Plexicon were the ones who developed the very first BRAF inhibitor brought to market, vemurafenib. And so they understood, like many scientists, whether it's my journey with Gleevec and Tasigna and the team there, EGFRs, BTKs, that you can innovate through mechanism. And so what they did is they added a steric side chain, which allowed us to bind in the ATP pocket, but in the out position. And what that does is prevent the hyperdimerization and activation downstream. And thus, we don't have that MAPK pathway activation, so it's safer in that setting. And it has a less sensitivity to the resistance pathways that we see with the class 1 agents. So this ends up being very, very selective. That is what leads to a lack of wild type impact across BRAF for the class 1 and 2 agents, or the pan-RAF inhibitors, where they're affecting A, B, and C RAF wild type. And thus, this is one of the reasons why we believe we have our class-leading tolerability and safety profile, which is really important to duration of benefit and ultimately part of efficacy.
Right. So you've got the selectivity for BRAF over other family members. You've got the prevention of dimerization. So you've got some safety advantages and tolerability advantages. What about patient burden? Because there's a whole lot of monitoring, right, that comes with these side effects of the combination therapy.
No, absolutely. And I think very simply, Selena, in a framework of why a clinician and a patient will choose a product. And it starts with efficacy, goes to safety, goes to tolerability, then goes to convenience, okay, and then goes to overall applicability, right? So within the framework, because of the safety issues that are raised by the mechanisms, the patients have to go visit an ocular specialist, a dermatologist, and a cardiologist every 2 months, in addition, of course, to the oncologist, in order to monitor the impacts of these therapies. And that's a burden for the system, for financially, but of course for fear and time for these patients. So we're optimistic based on our discrete mechanism of action and the clinical data that we've demonstrated that we can free the patients up from that and have a once-a-day dosing regimen so that the convenience is quite excellent. In fact, some of our patients are now out over 9 years on therapy, despite having failed other previous therapies. And that is indicative both of the discrete and differentiated mechanism of action for efficacy, but also for tolerability and safety. Because frankly, products fail patients because they can't take it. And in this case, it allows the patient to take the product. And one of our lead clinicians recently said that in her experience, the quality of life on plixorafenib is entirely different than her experience with the existing therapies. And she believes that will not only provide benefit from a day-to-day experience, but also from an efficacy standpoint.
Right. So you can grow the market in one sense just by being able to have something tolerable enough to keep patients on for it to be effective longer. But then you also have this ability to target like the class 1 and the class 2 BRAF. So that gives you some optionality in terms of indications. So one thing I think a lot of companies face, whether they're going for best in class, therapy in a space with other therapies, or whether it's first in class, in any case, if you have a very specific, mechanistic intervention that you think is useful across a variety of settings, like how do you decide where to start? So for you, you started in CNS tumors. You also have looking specifically at BRAF fusions, and then you have this kind of basket of rare things. Like, why was that the order that you decided to choose?
And I think anytime, this goes back to your original question about, where do you go and how do you develop the commercial opportunity as well as the scientific opportunity? And in this case, we at Fore decided to go with areas that had high unmet medical need, because the only therapies available for these patients are surgery, radiation, an old alkylating agent from my first stint in pharma, and in CNS, and then accelerated approvals for Tifenlar Mekinist in one population and Ojemda in another population. And that's really all they have available, unfortunately. Then when you look at fusion, it's even less. It's only for pediatric low-grade glioma, the rest of the patients. So the high unmet medical need, low optionality for them in terms of other options, and yet we can demonstrate benefit and value in a short period of time. So our first NDA submission is on track for the end of next year in the CNS population that you mentioned, and then closely thereafter followed by fusions and then the broad rare V600. So it's an area where there's great opportunity, there's high need, and we can demonstrate, thanks to the duration, a really good commercial benefit as well on these patient populations. To give you a sense of scale, we're talking 10,000 patients across the G7 and CNS, 33,000 in the fusion and 33,000 in the rare V600. So a really nice opportunity. And I think for your audience, the context of this is the BRAF is a very important alteration. It's in 8% of all tumors. Right, that's almost 2 million people across the G7, and you have a sizable commercial benefit there. Novartis has $2.5+ billion in sales, and the whole market is about $3 billion, but that's really only in about 30% of the epidemiology. So there's a really big opportunity there where we can come in, demonstrate our benefit, our differentiated profile, and then expand from there. So that's the rationale behind the strategy.
So I think in biotech, right, the clock is always ticking. Time is money. And I'm just wondering if other folks out there can learn from Fore's approach to, I'm specifically thinking here of your master protocol study. And so are there design features of that study that really help you with efficient development program?
Yes. So the Fore Master Protocol has three major arms to it. And in essence, the benefit of a master protocol, to your point, Selena, is it's very efficient. You go to a Memorial, a Johns Hopkins, a leading institution and or network, and you can get a singular review of that overall protocol, and then you can work within the key trials across that institution. So it's very efficient that way, along with working with CROs or other partners that help you execute against it. So that part is really nice because I can go with our team into a major institution and work across the head and neck group, the CNS group, the lung group, et cetera, to support the overall program. So that has a lot of benefits. Now, it is more complex to execute up front. You have to put in that time. You have to manage the translations and all of the amendment structures as a whole. But overall, it can be a very efficient way to reach a broader population and or target audience.
Reaching a broad population, definitely something you want to try to do as much as possible in precision medicine. So the fact that your molecule targets several types of BRAF mutations is an important one. And just think like across the industry, as these cancers subdivide and subdivide and subdivide, and you find these rare and rare drivers, is that going to be the answer? We just need to design molecules with that in mind, the ability to have a structure that works across many.
I think cancer is such a complex disease and set of diseases, as we've articulated, that we need multiple strategies and tactics to address this. So I am a big supporter of other innovative approaches and have had the privilege to work in some of them. Now, with that said, I think we are going to want to better and better understand the molecular drivers of the disease, the resistance pathways that do occur, and have interventions that we can either utilize in combination or sequence. And that will continue to evolve. Until we are curing all the patients, we have not reached our goal. Right. Now, I will often say there's never been a better time to have to be treated because of the knowledge that we currently have and the opportunities we have for scale across various institutions, clinical trial opportunities, et cetera. At the same time, we have a long way to go yet, because while we're having major improvements on patients' lives, we are still short of curing them at the rate and with the ease and tolerability that we would like to.
So you've been on both the large company side and the big and the small company side, and I'm wondering now if you look around at the ecosystem of smaller companies trying to do precision oncology, do you see common traps or mistakes that they fall into?
I think at a high level, there are some, and you've mentioned one or two of them, which is making sure you have clarity on the companion diagnostic path, the biomarkers, what that information tells you, and then translating that into where in the treatment paradigm you fit, you can demonstrate key value and benefit, and then what happens next. This is a key part of our overall ecosystem, meaning, okay, great, you're treating somebody in second line. What is the clinician needing to do next? And this can go into clinical trial design, inclusion, exclusion criteria, and how you fit in that treatment paradigm. Because if one group excludes a certain type of patient and you don't consider that, you may get reserved when you don't really, it's not an appropriate place for your product to be used. So being really clear on that and how then to work with the appropriate parts of the ecosystem, the major institutions, the clinical systems that are broad across the US and have access to a large number of patients. How do you real-time identify those patients so that they can again be brought into the trial at the right time? Those are all important, I'll call them operational or tactical components that need to be built into your protocols in order to optimize your patient identification and enrollment. Because even though the systems are often supportive, it's an incredibly complex dynamic for the clinicians and their staff and their teams. And to identify a patient and then bring them in is hard. And we know that there's far too little utilization of clinical trial for these exact patients, or excuse me, this type of patient overall across the US. And we'd love to see that number increase, and tactics like this would help make it more effective.
Yeah, well, okay, I'm looking at time here. I'm seeing we only have a couple of minutes left. So
No.
I want to switch gears because there's a different kind of question I wanted to get to before the end of this, which is that we often hear of executives at pharmas going or considering going to run biotechs. And you made this jump yourself, right, back in 2018. So I'm wondering what advice you might have for others who are thinking about doing that today.
Yeah, I mean, our life sciences industry is a remarkable thing to be part of, and there are many sections you can play important roles in. And I was attracted by the innovative aspects of biotech. I had spent 30 plus years in larger life sciences companies, and so I think it's important you start and understand your drivers, your motivation, and your skill set, and where you show up and work best. Because you can be an outstanding pharma executive or a biotech executive, and it may not be the best fit for you in the other way. What do I mean by that is, in essence, number one, you've got key decisions you have to make in a different way. Prioritization is always important. In biotech, it is binary. Okay, you have to factor in your financial runway in a different fashion. What are the key drivers of value inflection with your audiences across the investors as well as the employees, and of course the audience that you're trying to serve, ultimately the patients. But you have to factor in a really clear strategic prioritization towards indications, towards milestones, towards resources and capabilities. And that, I will say, is very different than the structure that you have in a portfolio of a larger organization and the choices. So that's number one. Number two is the talent and the nature of the talent. There's remarkable talent across biotech. I mean, these are some of the smartest people on the planet. They're very motivated and committed. Sometimes you have different experience levels, all right? And you don't have all the resources that you have at some of the other companies in terms of understanding the breadth of the patient population, the market opportunity. So your capabilities are very different, and they differ by stage of company. And so that's an aspect that you have to not only understand that, but embrace that. Okay.
We have to close here really quickly, but you're now a second-time CEO, no longer a first-time CEO. Is there like one thing you learned on your first go around that's still important to you in your second go round?
Absolutely. It's how to take some of those decisions in mind, considering where you are stage-wise, what your resources are, what your investor and board, I'll say framework and strategy is, aligning on that very clean, very early. And you have to, I'll say, I don't want to say this the wrong way, but you have to be really clean and clear about that while keeping your options open in a structured way. Okay. And having that and being clear on that is part of what drew me to Fore. You have a differentiated mechanism. You have a clear path towards value generation. You have a wonderful set of milestones. And ultimately, you have a profile that should be able to disrupt the current large but underserved opportunity. And so that clarity of focus and that path on technical risk being de-risked in many ways to value generation is a great place for us to be and add value.
Okay, well, speaking of the path to value generation, last thing, you have some milestones coming up. Tell people what they should be watching for next.
Yeah, we were very pleased last quarter to announce the clearance of our interim analysis in our V600 CNS protocol, which is our lead indication. That is on track very nicely in terms of enrollment and data generation to report top line third quarter of next year. Then to go into NDA submission, hopefully by the end of next year, and be available more broadly for patients in 27. So that's an awesome opportunity in the near term. Then our fusion population, we're looking at an interim analysis in the second quarter of next year, followed by another one in the latter part, and then shortly thereafter, NDA submission. And the rare V600, 3 to 6 months behind that in each sequence. So we've got an excellent set of milestones, to your point, that are not 3-4 years out. They're not. We just passed one. We got another one in 6. We got another one in 9. We got another one in 12. So it's a wonderful place to build information and value inflection.
Well, the early data have certainly been compelling, and I wish you all the best of that. Thank you for coming on our show today and for the great conversation on how precision oncology has evolved and where it's going next.
Thank you, Selena. Really appreciate the opportunity to represent the talented women and men of the company and share this perspective with you for those patients.
Great. Thank you.
Brought to you by the 5th East-West Biopharma Summit in South Korea. In March, explore how to globalize Asia innovation and connect with key players across Asia's innovation arc, from India to China to Japan.
Kendall Square Orchestra provides the music for the BioCentury Show. The group connects science and technology professionals and other members of the greater Boston community to collaborate, innovate, and inspire through music while supporting causes related to healthcare and education.